So, Dr. Rickenbach, thank you very much.
Thank you very much indeed. I'm delighted to be here, and I'll take my mask off if that's all right with you, so you can hear. But I can't understand the wish to do that. And thank you for coming along this evening. It's great. Really appreciate the support and encouragement. And I'm going to talk about life as a GP at Park and St Francis Surgery, because I've been there for almost 30 years now. And at the top of the screen there, you'll see Park Surgery, which of course you all know, and at the bottom you'll see St Francis Surgery. And next, is that lovely? I see, yeah. And what we're going to talk about is I think we'll do next slide, won't we, Peter? So I'm Mark Rickenbach, as you've heard. I'm a GP, and I'm also visiting professor of healthcare at Winchester University. And I have a research interest. I've worked with Wessex Clinical Research Network, and an education interest because I've been an associate dean with Health Education England in the past. And I'm going to talk today about the history of the surgery a little bit, a bit about starting out as a general practitioner, something about the innovations that the patient participation group and the surgery have been involved with, something about what it was like back in 1990 and what it's like now and comparing it, and a little bit about the COVID, of course. So next slide. You'll see here a map. And this map shows Park Road, and there's a big red arrow, and that is the original Park Surgery. And Park Surgery was then known as Radthorne. The name's changed, but the house is still there. And I have been there, and I'm going to show you some pictures of what it might look like. Not exactly. And you can also see the new building to the left with the red marker on, so where Park Surgery is now, on the junction of Hursley Road and Southerners Way. On the next slide, you will see that there is a house very similar to the one there. Now, obviously, I haven't taken a picture of the exact house, but it's a Victorian house, and it was 1897 when Dr. Edward Duguid Ritchie established the practice. So it's more than 100 years ago now. And he set up the practice as a single-handed practice until he died in 1912. And in his memorial, his wife set up the Ritchie Hall and the Ritchie Memorial that you may well know. And when we look at the next space on the slide, we will see the Nissen hut, which has been put up on the site, and that was done in 1940. And this was a temporary residence. And the surgery was run in there, and patients told me about this I've seen over the years, and they told me about how they used to queue under the blossom of the apple tree to see what was then Dr. Sibley. And the doctors between then and Dr. Sibley, there was Dr. Livingstone and Dr. Misquith, and Dr. Sibley, and some of these doctors you may know or hear about, or be familiar with, and I'll be interested to know your memories as we come to the end of the talk. You can see Park Road there. On the left-hand side is the hedge, and the hedge is still there, and it's behind there that the original Park Surgery was. So, next slide. And you'll see on the right at the top, the doorbell. This must have been fairly original, but obviously it's an electric doorbell, I think. And it says on there, day at the top and night at the bottom. Because, of course, he was on call 24 hours a day, just him. And in the daytime, they'd ring and it'd be the downstairs room, and at night time, it'd ring and it'd be the upstairs in the bedroom that would call. And I can imagine him going out, probably with horse, with no antibiotics, with no active treatments that we knew about there, to look at his patients and share their difficulties with them and hopefully move them forward. And you can see here the original Ford of Chandler's Ford, according to this picture, which was at the end of Hursley Road, just before Park Road. And you can see the flooding that occurred 1 year. So next slide. And then we had Dr. Watson, Dr. Tony Watson, who I'm nodding of head shows that you remember him, in 1961, who moved into that original house. And he took on board Dr. Reggie Taylor, who you may also know, in 1966. And together they opened the first purpose-built building of Park Surgery. It was built on a slightly marshy pond area, and there is still a pond in the centre, which I have great pleasure in looking at. It keeps me going when I'm there. It housed at least 4 consulting rooms, and we have expanded it inside now. Next slide. So coming to myself now, I qualified in 1984, and you can see there some of my colleagues in the students in the same year as me. Note they're wearing tie and white coat. And of course, that's now gone out, and we'll be talking about comparisons over time. It's now short sleeves and open neck collar, no white coats. Medical student time was great. I was involved with the Edinburgh Fringe Festival, went cycling, and really enjoyed my time as a student. I lived in the East End of London and went to the London Hospital, and the Isle of Dogs was where I was staying. There was one building standing up on the Isle of Dogs. It was all desolate wasteland, and that one building was deemed unfit for human habitation apart from students, so it was great. Used to scrape the frost off the window in the morning and look out onto the deserted dockland and see the birds there and the riot police training. I really enjoyed it. So we came to 1990. 1990, I went to Australia, and I worked as a registrar in cardiology and worked in the A&E department in Perth in Western Australia. Between 84 and 90, I'd worked in various hospital jobs. I'd qualified as a hospital consultant, and I decided that actually general practice was the right thing for me because I could do everything and I needed to know everything rather than specialize in one particular area. So I moved into my GP training in 1990 after I got back from Australia. And then I did a little bit of work as a locum and then joined the practice in 1991. And you'll see here a picture of the lakes in Lakewood Road. And my wife was feeding our second born just by the lakes as I went for my interview. And I came back and told her I got the job, and we were delighted. And then we both went for trial by sherry, where you meet the senior partner in their house and you all have a glass of sherry and say hello to everybody. So on the next slide, you'll see the range of conditions that a GP saw in that time, and indeed today, is very similar. I was looking after babies, and I've run a baby clinic all the way through my career. And it's the delight to see the 6-week-old babies giggling and laughing and looking at you. And that's probably one of the reasons why I've now got 3 children as opposed to 2, because I enjoyed it so much. Of course, we also deal with the stresses of middle age and older age and palliative care. And I've had the pleasure of seeing my babies grow up and become adults and have their own children, which is really nice, or the adults grow older. And you'll see on the picture at the bottom in a minute, next slide, is the school gates. And of course, I'd meet a lot of my patients at the school gates. I lived on site, and I still do, like Dr. Ritchie did back in 1897. And therefore, I would have a consultation sometimes, but I would say it's confidential and we need to meet at the surgery afterwards. And initially, I'd see mostly mums and babies. But as I got older, I grew older with all my patients. And so I met them at other stages. And now I see more middle-aged and older. And next slide, you'll see that one of the consequences of being in your own area and living in your own area and meeting patients is you meet them in the supermarket, which is slightly awkward if you're buying alcohol for a party and you've just given advice to someone to cut down their alcohol. 2 consecutive weeks that happened, but not since then. So on the next slide, you'll see, it's not actually my wife, it's a stand-in for me, but she was looking after our baby child at the time. This is our second born now, it would have been. But she had to be acting as a receptionist for me, again, like Dr. Ritchie would have done in 1897. She had to contact me by pager. There was no telephones in those days. So if you look at that next slide, you'll find the pager appears. And your next slide, you'll see that my mobile phone appears. And that was the sort of state of play of mobile phones in those days. Obviously, we didn't have one. So I had to go to a patient's house and ring from a patient's house. And sometimes that could be difficult if the phone was a bit damp for some reason. But anyway, we carried on with that. At that time, I had working an 8 to 8 day, roughly. 38 appointments, 19 patients in the morning, 19 in the afternoon, with extras. But the things that we saw were much quicker and briefer. It was one thing usually, and it'd be fairly straightforward. And we'd have in the middle of the day 2 or 3 visits. And then on top of the surgery, I'd be doing a duty call, and I might be called up for a heart attack or a stroke or somebody who'd had an injury. And that would be on top of the normal routine day. Now we have a duty session and we don't run a routine surgery. Other people help with the visits, and we see about 12 to 15 appointments in the morning with no extras. So it's changed the pattern. But the appointment numbers have increased, I hasten to add. As a doctor, I was doing the duty calls and the surgery, but also I was looking after a list of 2,000 people and all the paperwork associated, looking after them and making sure they're okay. And on top of that, I'm the manager looking after the practice alongside our practice manager. So a GP is doing 3 different roles, and they still are today. A salaried GP might not do the management, but they might still have a list. Back in those days, the practice manager carried all our paperwork round in a plastic bag. There was no other bits and pieces needed. It was very straightforward. Now we've got an administrative team of what may be around about 10, including Louise at the back, who's very kindly helping with the PPG. Next slide. Our records then were Lloyd George records. Now, Lloyd George was the Premier or Prime Minister in 1911. And he set up these records, which must now be antiques because you've still got them around and you'll all have your own records within them. They're stored away now, but at that time we had to write on those, and we had usually one line for one attendance. It would be something like sore throat, penicillin, that's it. We had to summarize all these, and we moved them onto A4 paper for a short while. But then on the next slide, you'll see that we had a computer system in place. Initially very basic, but now it's really good with mouse and all the other gizmos that you need. So we can really check all the medical problems very quickly, and we have much more extensive records. They have to be much more extensive to hand on the information because things are much more complex nowadays, and because of medical legal reasons, we have more complaints and more medical legal issues. So that was the Lloyd George records, and on the next slide, you'll see the handwriting examples from that era. Now, one of the amazing things is computers have just moved everything forward. From my point of view, they've been as important as the discovery of a new treatment. But I don't have to have my handwriting read anymore. So that's great. I was writing hundreds of prescriptions, and there's no wonder that my handwriting got a bit mucky at the time. Initially, all the prescriptions were handwritten, thousands. And our receptionist would handwrite them for us and we'd sign them. But now, of course, it's all electronic. And on the right side there, you'll see the different consultation styles that emerged over the years. So when I started out in practice, we consulted across a table. There was no computer, but we did have a rapport and relationship. Now we consult at the side so that the table doesn't get in the way of our consultation. And we try and keep eye contact and build a good rapport, and we're trained in that area. We've got a computer on the table. And obviously one of the problems is you can look at the computer and not at the person. So you need to be careful about what you're doing and try and keep that contact in place. And we're wearing masks now, so that limits our communication. And of course, at the start of COVID, we were also working on the phone, so it's even more difficult. So the important thing for us was the continuity. We knew our patients well enough to be able to talk over the phone and maintain some sort of relationship. Next slide. Well, we come to the patient participation group. And this patient participation group was first established around about 1995. There was Dr. Sally Bacon and Dr. Kathy Fowler, who's just retired, and some of you may know. who set up that with my input as well. And over the years, the patient participation group has been involved in lots of different ways with the practice. On the next slide, you'll see the health walks. Now, the health walks was an idea that emerged in 1999 when I sat down with the PPG, and in particular with Peter Fortescue. On the back of an envelope, we sketched out a few walks in the local area to help people after surgery or to rehabilitate from illness or just to get fitter. And they were half mile up to 6 mile. And on the next slide, you'll see that we had a sketch of the local area. And this is an example of one of the cards that we used to have. And we handed them out to patients and they walked around the area. That's expanded now, and partly thanks on a national basis to a colleague in my year at medical school. 2015 was when we spoke at the anniversary dinner at Christmas for the health walks process. There was several hundred people there. And at that time, they were doing 10 walks a week, 250 people a week, 400,000 miles over 15 years. That's pretty impressive. And I'm sure you've all seen people walking around in groups. You're probably members of the health walks yourselves. And if you're not, do join in. Great. On the next slide, you will hear a bit more about what's been happening with the patient participation group. You have an active committee, and thank you. You have a virtual group. We've sort of heard of several thousand people that can be emailed. You produce regular surveys each year, and that had originally led to a change in the phone system. And now, 3 weeks ago, we had a new phone system again in response to feedback we've had from the PPG. You put in place the screens. Lillian Hobbs in particular helped put those screens at each surgery, which tell you about what's going on. We've had representation regionally for things like diabetes, and Dennis Pearce was involved with that. And as a PPG, you've been a regional lead. Jan Bland and the team have all represented the PPG at national regional meetings and encouraged other PPGs and supported them. You've got your newsletter, you've got the information stands, which have stopped just for COVID, but hopefully will restart. And you've been involved with research. And we've had representation at the University of Winchester with Mike Wilson, and we've had links in with Southampton and Professor Holgate through Frank Anderson. Next page, or next slide. I'm bringing you forward to 2002 now. St. Francis Surgery gets built. It's Simon Chaplin-Rogers, Dr. Simon Chaplin-Rogers at the front there, bowed down as he's walking in, who actually was very closely involved with the design. If it hadn't been for him, I don't think we'd have had a surgery at all. They didn't have any plans for it. And you can also recognise Pauline Denyer and Jenny Chalk there, amongst others, who you may know from reception work. It was a round tower design, so we got some cheese-shaped rooms there. And you'll see a red arrow there, which is just above the veterinary surgery. Now, the veterinary surgery used to be the branch surgery. And when I started in general practice, I used to sleep in that branch surgery at night. I was sleeping on the camp bed at the time. I was doing 1 in 5 nights. And because I was commuting from Portsmouth to Chandler's Ford, I needed somewhere to stay. And it seemed a logical thing to do. The youth used to come round and bang on the windows and try and wake me up. It was fun. But it was a lot better than when I started out. We had Dr. Ritchie doing every night. When I started out, I did every second night. I would work through the day, do the night, work the next day. On the weekends, I would start on Friday at about 8 o'clock. I would work through all the nights until I finished on Monday around about 6 or 7 o'clock. That was every second weekend when I started in medical work. And as I moved through, obviously things got easier. And now we don't do any night calls because we have an out-of-hours service. So that's been a big step forward. That red arrow also shows you that in the veterinary surgery, we did, when it changed across to veterinary surgery, we had several patients who actually went along and sat and waited for their doctor in the veterinary surgery. They looked around, saw the dog food, but it took them a little while. Next slide. The opportunity here was we've got 2 surgeries and there's a path in between. And it's quicker to rollerblade than to drive. So I used to rollerblade from one surgery to the other. We'd have a meeting at 8 o'clock on Friday morning, finished about 9:30, I'd rollerblade across to Park Surgery, and then at the end of the surgery, I'd rollerblade back for duty or the minor operations on Friday afternoon. And the next picture will show you that I did wear protection. So if you saw me, I'd have been wearing helmet, backpack, elbow pads, knee pads. And this was in London at the rollerblade marathon at the time. The next slide will show you that we also had dogs in the surgery. Not in the surgery, but it's a theme with our surgery. And 4 of the doctors in the surgery have schnauzers. Dr. Chaplain Rogers, Dr. Sam Glanville, Dr. Jane O'Connor, and myself. And pets do make a difference. They help with mental health, they help with physical activity. And if you want to get more involved in that, Pets as Therapy is one of the websites you can go to. On the next slide, you will see that we got involved with teaching. I was interested in teaching, and we started to accredit ourselves as a teaching practice back in 1994. Since then, we've had a registrar working with us, at least 1 or 2 a year. And registrars are very experienced in the hospital setting. They're just learning about how to work in general practice. And in general practice, we see a lot of people with less severe illness, and we have to pick out the serious illness. And we do it by taking the history as much as anything else. In the hospital, they see people who already have serious illness, and they do lots of tests, and they have to adjust to that. And that's one of the skills that they develop. And you'll see Dr. Emmanuel Umaru here and Dr. Lamia Elnahas on the right. And now we have a group of some 15 to 30, I suppose, almost, registrars and doctors who've had experience of our practice. And we have a sort of family of GPs who've worked locally, who worked in the country, and some have gone abroad and come back again. So it's really nice having that support. And of course, it gives us extra service. There's more time for those people to actually listen. They have longer appointments. And so it's really helpful for us. On the next slide, you will see that as a PPG and as patients, you also help raise money for charity. I was very keen that we raise money, and I'm sure you are, for cancer care research. And so we've, as a group, and you'll see in the next picture, the 40 or so cyclists from the local area did a regular route down to Europe. They might go to Rome. I met or waved at the Pope there and met the Pope's emissary in Rome, or Monaco, or Gibraltar, or Barcelona, about 1,500 miles, and they cycled for 100 miles a day. And they raised about £50,000 each cycle ride, and roughly £400,000 so far overall for cancer care research. And that was thanks to yourselves, because many of you would have donated to that. That was really great. Next one. And of course, cycling keeps you fit and healthy. Innovations in healthcare. So in healthcare, we looked at frailty care. People who are less able to look after themselves, what can we do to keep them independent at home and prevent them having to go into hospital? And we put together a team and involved social and healthcare, which was quite innovative at the time. This was probably 10 years ago now. We've had permission, by the way, for all these photos, or they're bought photos, so that you know that we've had that. The frailty clinic that we set up in the surgery has now led on to a frailty service led by a consultant and a paramedic and a nurse. And they are helping us to look after people who are struggling at home. We also have a transformation team which has been put in place, which helps with the chronic social care. So there's quite a team now that's evolved from that single GP. On the next slide, you'll see that we became involved with counselling. And at the moment with COVID, that's quite an important issue. You'll see on the next slide the posters that we produced and took nationally about the counselling service. And this service is unique because it helps support the local colleges who are training counsellors. And they come to us for their 100 hours training in their last year. And in so doing, they contribute to the service and help our patients. We have a coordinator, in this case, Ken Lawrence, who helps organise things. And previously it was Christine Dunkley who founded it. And we have a supervisor who meets with them once a month to help develop their skills. And this has become a national model. It's been on the National Institute of Clinical Excellence website and has been recognized at conference presentations. The next one will show the London Olympics. Now, I'm very lucky to have been at the London Olympics, as have many people like Debbie in the audience. And it's been really good to be involved with that. You can see a picture here of the Smurf turf. The pink and blue, they call it Smurf because of the colours. And this is the hockey pitch. And the hockey pitch is actually a waterlogged synthetic pitch. And it's waterlogged to actually make the hockey ball travel faster, 100 miles an hour roughly. And hockey is one of those situations where you get lots of injuries. Almost every game I was having to go on and help with the team to pick up someone who'd been injured, often with the hockey stick, but sometimes with falls. And you can just about make me out there with a sort of green bag on the back and wearing one of the caps. We had a lot of training, but the training was mostly about how to carry a stretcher onto and off the pitch without making an idiot of yourself. Because it's very easy, and my kids showed me clips of how you can pick up a stretcher and the head of the patient goes between your legs, or you can run into the patient and slide and hit them with your feet. None of that happened, I'm pleased to say, so we got away with it. This gentleman had a dislocated shoulder, and we have a team here around of an orthopedic surgeon, an A&E consultant, a nurse, a physiotherapist, and a GP. You can imagine there's a lot of discussion about how you do things. And one of the ways you can replace a shoulder that's been dislocated is putting your foot into the armpit and pulling. I've done that in the past. Or you can manipulate the arm like this. Or you can just ask the patient to lie on their front and hold a weight, and the socket and the shoulder joint goes back into the socket. So after much discussion, that's what we did. And he was fine afterwards and very keen to get back on the pitch. They're amazingly brave hockey players. I've had the captain who fractured her jaw, went back on and played 2 days later with a plate in place. And when we were stitching people up, they were saying, please, quick, 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 we want to get back on the pitch. Yeah, so it's amazing, really good team. And it was a great experience, wasn't it? Yeah. So next slide. This led on to the community games, and people here have been involved with this on an annual basis, and the aim was to promote physical activity, and the surgery and the PPG contributed people to these games, and we helped with a first aid stand in particular with our nurses and team members. At the same time, we also were involved with the St. Francis Cafe, which helps support people. There was the Health Walks prescription scheme. There was the Arts prescription scheme, which is still going, thanks to our local GP, Peter White. And there was a books on prescription, health books this was. So there's lots of innovation happening at the time. And on the next slide, I want to move on to the consultations themselves now. We have 7 minutes face-to-face for a consultation. Now, it's a 10-minute appointment slot. When I started, 1991, we had 5-minute appointments and 7-minute appointments. Now, the national average is about 12 minutes. It depends on which area you're in, 9 to 12 minutes. We have approximately a minute or so at the start to look at the records and see what's happened in the past and work out what needs to be done today. At the end, we have another minute or so to do the tests, do the investigation, write the referrals, and write the notes. So you can see it's quite tight to get the consultation in place. And we want to listen. We want to have a golden minute of listening if we can. We want to examine. We want to help share the options. We want to help share the management. And those things about sharing the options and sharing the management are things that have come in over the last 20 years when you compare it to the probably 1897, when it was very much the doctor said. Now it's very much a shared approach. On the next slide, you'll see that we looked at ways we could make the consultation more efficient. And there's the thing called ICE, ideas, concerns, and expectations. Now, the consultation is a bit like an iceberg. People come in with the one thing, and actually there's a lot of other things they want to talk about or relate to it. They might come in with pain on the side, but actually there is more to it. It might be that the financial issues or relationship issues or home problems or work problems are aggravating that pain and making it go on much longer than we'd expect. So it's about finding out what's going on and finding out what your ideas are about your illness, what your concerns are about it. Is it cancer or what? And what your expectations of how we handle it, scan or not, are very important. And in many cases, people don't want an antibiotic. They just want reassurance. So it's something that's quite important to know. And in many cases also, people will know what the problem is and tell us, and it will be much more straightforward because we're all on the same page. Good thing to listen to people, and they'll tell you. Next one shows that we then took this to conferences nationally. Overall, over the years, we've published about 40 papers. We've had about 30 presentations, about 20 posters at conferences in various sites. And this was an example of one where we had 100 patients who had gone through the process of writing down before the consultation what their ideas, concerns, and expectations were. And because they did that, it made the consultation easier. And the doctors were very pleased with it, and patients were very pleased with it. Some of you may have completed them. It won a national award because it was quite innovative in approach. And now it's been superseded by eConsult, which I'm sure you've all been so excited to use. eConsult is going to be superseded. I'm hoping that those ideas, concerns, and expectations will come back in more clearly, and it'll be more simple and straightforward. On the next slide, and the next one. We got stuck somehow. We'll come forward to 2019. 2019, just before COVID, we established the Chandlersford Primary Care Network. This is with Friern Surgery, and there's some 30,000 patients in total. Most organisations, and over the years, 30 years, I've seen so many reorganisations. It's just one of the things that government likes to do, I think. This is the first one that's actually had an impact at local level. And we have had additional roles funded for us. We've had a social prescriber who looks at benefits for an individual, financial support, looks at how they can maintain their independence at home, and supports the carers for them. We've had a first contact physiotherapist that you can book in directly to for your aches in the shoulder or back. That's Joe Jenkins. It's Julie Bithell, who's the social prescriber. And we have a pharmacy team now who are doing those thousands of prescriptions I mentioned. We are also having a mental health nurse who's going to be joining us, or in fact has already joined us in the last few weeks to help with the increased workload that's hit us with COVID. And we have paramedics joining us to help with our visiting. So there's lots of new roles coming on board. The team's expanding. We have some 55 people now employed, as opposed to the one GP in the start. Some roles, however, have changed, and we used to have our health visitors, community nurses, and midwives all in the surgery. Unfortunately, they've all been taken away and moved to more central resources. So benefits and disadvantages there. It's during this time that the surgery had a chance to talk, or I was involved in Radio Solent, and we did a few talks on teenage exam stresses, mental health. On here, you've got connect with others, be active, take notice, learn and give. They're tips about maintaining your mental health. Meet with other people, do physical activity, look at your environment, learn something new each day, and give something, whether it's a smile, a chat, or your time. Next one. A big thank you for the research. I've already mentioned that we're involved in it. Panoramic is the current research project. If you get COVID, you can get access to new COVID treatments, and you can help our knowledge move forward about those treatments. The principal study has been a real success in the last 2 years on an international level, and we were involved with it. This looked at existing medications, and we showed that antibiotics didn't help COVID. It showed that inhaled steroids used for asthma does help COVID infections and reduce complications. It showed that some of the treatments that President Trump took, it doesn't help. Hydroxychloroquine, no. Washing out with Dettol? No, that wasn't in the study. We have more recently looked at contraception devices, and I've been involved with some papers looking at ways of cutting the threads that come with contraceptive devices in the womb, ways of providing analgesia beforehand, prior application. And we've been involved with continuity of care. I've led as part of a national project with 5 sites across England, looking at ways we can improve continuity for 500,000 patients. And the results have come out now and shown there is an improvement in continuity. And as a practice, we strive for it, although it might not seem like that at the moment with COVID and all that's happening. And thank you for your involvement with COPD, chronic obstructive pulmonary disease. If you've been involved with that, you've had additional inhalers, and we've shown the benefits of those. So lots of research activity. And the next slide. So looking back 1990 to 2020, we have less emergencies. I get called out to less emergencies than I did when I started in practice. In practice, I would be seeing a heart attack or a stroke every week. I might be resuscitating somebody every few weeks. That has not happened to me for several years now. And partly that's prevention, and partly that's because the ambulance service is responsive and we have rapid treatments. We can now dissolve clots that cause strokes and heart attacks. I couldn't do that when I started out. I used to look after people at home if they had a heart attack or a stroke in many cases. The treatments, however, have become more complex, and we're handling a lot of stuff that was handled in the hospital. In fact, most things are handled by us now. The appointment numbers you'll find have increased, and the duration has increased, but it might not seem like that because we're getting so much more work from the hospital. We now have out-of-hours support, and we now have a visiting service in place in response to COVID as much as anything else. And we've had an expansion of our practice team. I said 55 at the moment. Chronic disease has moved to us. We do all the asthma care and the diabetes care, for example, all done in the hospital. And at the same time, the government has increased our targets. Anything they can measure, they'll set as a target. They've stepped back a little bit with COVID, but there has still been that issue. And that tends to divert us from what we feel is the most important bit, which is discussing things and talking to the patient in front of us. Expectations have risen, not only amongst ourselves as patients, but ourselves as doctors. We want to do more and can do more, and patients expect more. Next slide. So now for the last bit, I just want to talk briefly about COVID. I'm bringing you forward to the 8th of March, 2020, my son's birthday. And I had COVID. I must have been one of the first GPs to have COVID. The first cases were about January that year. And I realized that I was literally learning about the disease at the same time as everyone else was. And all of us were learning about the disease. I developed a cough and it was dry, and it was less when I lay on my front. And now we have proning, or lying on your front if you're on ITU. I lost my sense of taste. I couldn't taste coffee. And I was absolutely tired. I was asleep almost all the day, just got up for food and so forth. That was for 3 weeks. My wife is a physiotherapist and had read about the fact that oxygen tends to dip in the blood. So we got some oximeters out. And I didn't dip below that crucial 95% oxygen saturation level. And despite some very odd rashes, I managed to stay out of hospital. But after that illness, I realized that the importance of oxygen monitoring. And we persuaded the CCG, the Clinical Commissioning Group, to get oxygen saturation monitors for every surgery in Hampshire. And that helped GPs manage the care, and yourselves as patients and ourselves as patients manage our own illness. That, we think, made a big difference, and it led on to virtual wards where remote monitoring of people at home was taking place using oxygen saturation monitors that were delivered to their house. You'll see my nails there, and you can just about make a line across those nails. They're called Bowes lines, and they occur when somebody's been through an illness, in the same way that you might lose your hair when you've been through an illness. I was asked before I did this talk, how about reception team and the staff? Well, they were really under pressure. Not only were they under pressure from the day-to-day work and changing the system, but they were under pressure from the risk of illness. And we were all under pressure. We were all handling the unknown. For a male nurse in our surgery, the risk of them getting COVID was 4.5 times the national average. And for those working in social care at the nursing homes, their risk was extremely high as well. Amongst the GPs who died, most of them were BAME, Black and minority ethnic. I was lucky. The next slide. The surgery seemed to change every week after I got back after that COVID infection. And first of all, the chairs became separated and then the chairs stopped. Then we had social distancing. We had markers there. We had barriers in front of reception. We've had plastic screens up. We've got masks, gowns, gloves. It's all changing. Next slide. Come forward to 2021. We really appreciated the clapping. It's great. And all the thank you messages and notes that you remember out there. This is somebody's wall in Hampshire with a rainbow painted on it. I was involved with a video in New Zealand looking at COVID and how we tackled COVID. There's been some 17 million cases of COVID in the UK up to now. 158,000 people, sadly, have died, and that's 5.7 million worldwide. We've got people who have long COVID, 1.3 million. And we are doing a study as a surgery on long COVID and how a little bit of movement every half hour might help people recover from long COVID. That study is going on now. We're going to be recruiting in the next few months. Next slide. This is me in a garden consultation, and we brought our own chairs. We did the consultations through the window or through the patio when we were doing home visits. We wore scrubs, and again, if we're seeing people and examining them, we'd have gloves and masks and gowns on. We had hot sites and cold sites. The hot blue on the right, St. Francis and Park were cold sites. The hot site, one was in Romsey, and we used to go along and see patients there. In this last year, we've had 375 million appointments in the UK. That's the highest ever. It's something like 15 to 30% increase in appointments, 15 to 20% over. And that's about 6 appointments a person. I'm not sure many of you would have had 6 appointments, but just think about it. Next slide. Oh, next picture shows me having vaccines. And of course, vaccination has made the big difference. On the next slide, you'll see a poem. And I'm going to read it out if I can find it here. About the choice of vaccines. A fortunate vaccine, Vex, in 2021. It was Pfizer versus Oxford AstraZeneca back then. Some thought they had a choice somehow. Others had to take first come, first serve. The decision was no sum. It seems the choice, if given, was not so clear. mRNA from 1990s studies was now here, but viral injected DNA had been around for years. Decision-making and false news just stoked up all the fears. But remember how fortunate we all were, as vaccines cure and hold the COVID exit door ajar. A miracle of science to smallpox Jenner we owe, a glimpse of light above in the COVID dark tunnel below. The solution I suggest for you and me is much easier, as you will see. P for Pfizer is at the middle, and A or Z for AstraZeneca is at the ends of the English alphabet. So just go with what you're given and accept is what you get. And we've been so lucky to have those vaccines and to get to our 3rd booster and to be protected. We have the only people on ITU really are those intensive care units, are those people who haven't had the vaccinations. Which leads me to the next slide. And the yellow placards that you may have seen around. Now, I saw these in Liverpool when we were presenting some of the research that we've done as a practice at a conference there. And the first one says, can we trust the media? Well, that sort of draws you in because we all think, oh, can we? But about the 5th or 6th one in of these placards was talking about the number of deaths from COVID vaccination. Now, we've had no deaths in our surgery. And we have 17,000 patients We've had no serious reactions in our surgery. And I went up to these anti-vaxxers and I said to them, if you haven't had the vaccine, you really need to be at home. You're in the middle of a pandemic, you should be isolating. And they thought about it, and I think they got the message in the end. But it's very difficult, and I really want to encourage them. And anyone who hasn't had your vaccination, come and get one. It's well worth it. It'll make a difference to your life, I tell you. And the last slide, I think, February 2020. We're here now. We've had a journey in history from 1897, and I can say, with hand on heart, that we have better care. I see less heart attacks, I see less strokes, I see less severe rheumatoid arthritis, I see less chronic conditions. That's really good. I see more care is provided within general practice. Something like 92% of healthcare takes place in general practice, and we have something like 9% of the budget or less for general practice. And we have a much wider team. So I hope I can be positive in February 2022. It is difficult still to get appointments, but there's more of them. So I can't quite understand that. We are working on it. And I just want to thank you very much indeed, next slide, for listening and for being part of the PPG and part of our patient population and all that we've achieved over these 30 years and many years since Dr. Ritchie. Thank you very much indeed.